Denise, Alita, I'm going to get started if that's okay with you guys. Very good. So, welcome everybody. My name is Kelly Kaberzagi. It's a pleasure to see all of you virtually. Um, I currently have the pleasure of serving as the Senior Associate Dean for Education at Oregon Health and Science University, which is located in the United States, and also have the pleasure of serving as the co-chair for our ICBHPE webinar series with my colleagues Ben Kinnear at the University of Cincinnati and Adele Atkinson at Sick Kids in Toronto. Today is our third installment of our webinar series, and if you remember, we're leveraging our series this year in 2026 to focus on the narrative. We know that narrative has long been recognized as central to the meaning making and learning in medical education. It allows us to leverage emotion and context and make sense of the world, and to be able to connect experiences with meaning, to be able to build connections within and between communities. And oftentimes by using stories, we're able to take and break down the abstract constructs into concrete clinical, or I'm sorry, into transferable, relatable, and using empathy. Um, what they do, stories facilitate the transmission of tacit knowledge and professional wisdom that is not easily captured in checklists or milestones. So I'm pleased to welcome our two guests today, Dr. Alita Chan and Dr. Denise Roney. I'm going to very briefly, Alita is Director of Assessment and Professor at University of Arkansas Medical School in the College of Pharmacy there in the United States as well. In the United States, and Denise Roney is also one of our pharmacy colleagues. She's a distinguished professor at the University of North Carolina. I will encourage everybody to please be sure to use the chat function liberally. Myself, Adele, and Ben will be monitoring that and being able to ask questions. Because of the nature of our event today, we'll start with just by having the stories, and I think Alita and Chan will, Alita and Denise will be kind of talking back and forth in narrative. And we'll save our questions to the end, but let's not wait to put questions into the chat until the end. Um, Feel free to add as many questions as we can. We'll be monitoring those and definitely have time for audience interaction and participation down the road. Very good. Denise, I'll hand it over to you.
Great. Thank you so much, Kelly. Thank you all for being here. Good morning, good evening, good afternoon, depending on where you are in the world. We appreciate you being here and sharing this time with us today. What you're going to hear today is a story kind of told in three parts. A story about our journey in pharmacy education as we begin exploring competency-based pharmacy education, and really started listening carefully to stakeholder reactions as we started sharing it. I think it's important that you understand that for pharmacy education that we're very much in the exploration stage, and you'll see why we're still in this exploration stage through these stories. So we're not here to present our finished model. We're not here to suggest that we suddenly flipped a switch and pharmacy education in the United States is now competency-based. But within this exploration stage, we were really just trying to understand the problem we were solving, trying to understand what competency-based education meant for pharmacy, and trying to understand if this change was even possible in our current environment. When we began this work, we started as a task force. I worked as chair of this task force for the American Association of Colleges of Pharmacy, and they wanted us to just see, what is CBE and pharmacy education and what it might mean. And I think Alita was on that initial task force group. And I think we thought the hardest part was going to be figuring out the structure, the logistics, and all the design issues, challenges such as the assessment systems, progression models, milestones, how we're going to organize the curriculum differently. So in other words, we really thought the hard work was going to be technical and structural. But one of the earliest surprises was that resistance surfaced well before any talk about reform, or even if we were going to do it, began. In many cases, it appeared the actual moment we said the words competency-based education, you could see the fear and the red face rising anytime we mentioned the word competency-based education. So the term itself really changed the tone of the room. So over time, we began to realize that this resistance is not just blocking the conversation, it was actually telling us something really important. It was telling us something about stakeholders, about their readiness, about their beliefs, and about their concerns. And we certainly realized that this is really where the hard work was, and the hard work had to begin there. So looking back now, some of the most important lessons we learned did not come from uh, thinking about the implementation pieces. It came from those reactions that we encountered along the way. So we're going to share some of those moments from that journey and what we learned and what we did ultimately in our work to help lead this national effort here in the United States to lead pharmacy education towards CBE. So we really at the very beginning realized that resistance is often easy to misread, but resistance is information to us. So it tells us the language. It tells us where language is getting in the way, where urgency is missing, and support is lacking. So resistance kind of clarified our journey. So first story is here, and I've titled it "The Room Changed When We Said CBE," and it felt like I needed to wear a bulletproof vest. This moment happened early in the work of our task force, and I had to give an interim report a few months in to this work at our meeting. The American Association of Colleges of Pharmacy has an interim meeting, and I had to give the report of the task force. So our task force again was really centered around using implementation science and using this heptagon tool to answer two important questions. Is competency-based education right for pharmacy education, and can we do it the right way? So clearly just exploratory. So we were not proposing that programs change anything immediately. The interim report was just there to share our early thinking, open dialogue, help people begin to engage with what's possible with CBE. So our work was defining the problem, think through implications, start discussing it. Again, not rolling out a full model, just really wanted to have a conversation starter. I went into the meeting really expecting a lot of questions. I expected some skepticism, but I still had really, really seriously hoped to have some good curiosity and openness. But I remember going in that room and a sense of tension just building. Once I started presenting, the tone of the room shifted very quickly. The comments became overwhelmingly negative, and what struck me most is that most comments did not begin with curiosity at all. They began with shutdown language, and many of you may be familiar with some of these phrases I'm going to say that I heard. This is not feasible. This will not work at scale. We don't have the resources. This is not how our programs are structured. This is going to create general chaos. We don't have time for this. But one particular thing came up again and again, and many of you also have probably heard this. Accreditation will not allow it. In pharmacy education, that statement can shut down any conversation almost immediately. Once accreditation enters the conversation, the discussion shifts from should we explore this to why were you even thinking about it? Instead of asking what problem are we trying to solve, what does this actually mean? Are some of these ideas actually align with what we say we value as educators? The conversation shifted to a list of reasons of why it couldn't work. This is exactly what it felt like. I honestly can't remember one positive comment. What I remember most was one dramatic objection. It was the accumulation of negativity. Everything seemed to come back to it couldn't work for some reason. As you can imagine, I left pretty discouraged and honestly a bit stunned. It felt like we hadn't even gotten to a place where people were really arguing the substance of the ideas. It's just the phrase of CBE itself carried so much baggage that the conversation barely got off ground. And I remember joking with people afterwards that I needed a bulletproof vest to present that report if I ever had to do it again. But looking back, that moment became incredibly important, and it really became a shift in my thinking and a shift in the trajectory. At the time, it felt like rejection, but as I went back and reflected on the conversations, it became very diagnostic. What looked like opposition was actually more layered. The reaction revealed a lot of things to me. There was a general fear of disruption. There were assumptions about accreditation, concerns about workload and feasibility, the uncertainty about changing faculty roles, and most importantly, there was not yet a shared belief that a major change was even needed. In other words, this wasn't simply an implementation problem, it's a readiness problem. It was a stakeholder belief problem. We thought we were there to introduce a new educational model, but what we really uncovered were beliefs. So that moment revealed how quickly educators moved to feasibility and accreditation before even discussing purpose. It revealed uncertainty about what CBE is and what people would be asked to do differently. It revealed concern about time, structure, and disruption. But it also revealed that there was not yet that shared sense of change. So at that moment, I think it was important that we learned that this was not just resistance to implementation, it was resistance revealing readiness. So as we continued having conversations about the interim report and our task force that subsequently went to committees within the American Association of the Colleges of Pharmacy, we started also realizing that not everyone was resisting the same thing or saying the same thing. So now I'm going to turn over to Lita to tell the next part of the story.
Thanks for that setup, Denise, because that's the title of this story. It's really the lesson that we got from our stakeholders. Not everyone was resisting the same thing. A lot of times we think that resistance is just kind of one concept, right? That everyone has the same concern, or if we just can easily fix it with one thing. But as we began listening rather than talking, as conversations continued beyond that interim report, we really started hearing all these different concerns from different people. So let me talk through a few of them. Faculty, and this is probably one that many of us resonate with on this call. All of a sudden, there was a lot of uncertainty about this changing teaching role. Rather than, content delivery in the classroom, the change of the role of an educator in the learning process and journey. How do I do this? Am I prepared for this? How does this impact my workload? What will my boss say about my time spent? Those are all common questions. Promotion and tenure tied to teaching. There was also concerns about this coaching process and milestones and longitudinal assessments because they were very different than what we were currently doing. While we all have coached students in some ways, the idea of identifying milestones, looking at assessment longitudinally versus just tied to a course, an experiential learning time, whatever it may be, was a very different approach. There was also concern about how competence would be judged. Competence is a big word, and the judgment of that can sometimes feel very scary for people to decide. And then we move to another stakeholder. So our administrators, again, many people on this call probably resonate with the leadership role and questions that occur from that role. So for example, feasibility, can I make this work? How do my policies and my systems and my structures, my registrar's office, all of those things align and make this happen? What does my infrastructure need to be to make this happen? What uncertainty is there? Accountability externally with accreditors and other stakeholders. And how will this impact my reputation if I do this new model when others may not be doing the same thing? Our learners also had questions. How is this fair? What do I do when I don't get just a grade, right? What is the transparency in this? How do I progress? What happens if I don't progress? Is there ambiguity around this? What if someone doesn't grade me fairly? How do I move away from this traditional grading structure? And then our clinical educators, our preceptors, our practice members also had concerns. How does this fit within our real practice every day? How can we handle all of this workload? Who supports this work? And then how do I get development time to do this and to be able to fulfill this role? So if you see kind of these different concerns, we have a structured competency-based education language, but it really did produce different forms of hesitation, even skepticism and concern. And what we began to realize is that resistance was too simple of a label and probably not really a right label to give. Faculty weren't always resisting the exact same thing that the administrators were, and learners weren't worried about the same issues as preceptors. And of course, there was some overlap between them, but some people were reacting to the language, some people to the logistics, some to role changes, some to the lack of urgency. Do we really even need this? Is something broken that we need to fix? Some were not even against those ideas. They just didn't trust what the label implied. So it really mattered that we saw these differences because it suddenly became clear that this wasn't going to be solved by some single messaging or a single implementation strategy. We were dealing with multiple stakeholders, each with different beliefs, pressures, and readiness challenges. So we kind of came to a next point as part of this story. Readiness to change is uneven across stakeholders. Different stakeholders have different readiness to change. Their beliefs in whether or not CBE is a good thing are uneven. They also have different needs. And we really just need to interpret resistance, not count how many people are resistant. We need to understand it. And so it looked less like obstruction or barriers to what we wanted to get done and more like a map of needs. And once we saw that map, it changed our entire perspective because we realized something important. We couldn't just push forward into implementation without first understanding this concept of readiness more systematically. And it really changed our question when we understood they weren't all resisting the same thing. It was not how to explain CBE better. It was how can we understand readiness for change in a way that accounted for multiple stakeholders, multiple behaviors, and multiple sources of resistance. So in our next story, we're going to talk about pivoting, and I'm going to turn it back to Denise.
Thank you, Alita. So as you can see, as we started as a task force, our work became very different than what we had originally thought was the work was going to be. We really thought the work was going to be defining it, coming up with plans on how to implement, and moving forward. But after we kept hearing these different reasons and different conversations for pushback, we really had to pivot and think, how can we do this differently? How can we really focus instead of on how do we implement this to, what is out there in the literature to help us understand this readiness concept? So from the very get-go, I had started using implementation science principles when launching the task force. And as we moved into our committee work, we continued with this implementation science framework and really understood that there was a whole literature base out there on readiness to change. So of course we did, and we looked into the readiness to change literature, and we found some readiness to change instruments. Some I think many of you had published on and had used. What we had found is, and one of the most common is the R equals MC squared instrument. That's a very common one for practice change and also for some educational change. But what we found is that instrument is more organizational change. It kind of tells you whether a general institution is ready for change. Says, does the leadership support it? Do they have resources needed? Generally is the cultural supportive. And I think that's great, and that's important. The organizational readiness is really important. But I think what we felt we were facing, it was a little more complicated. All of you on this call know the complexity of implementing a CBE system. And it's a gigantic philosophical shift. And we felt like with the many different stakeholders that were so important for making this work, that and because they were all not showing the same level of readiness, we had concerns that an organizational readiness tool may not tell us all the information that we need. And I know that myself and Alita had both been involved in curricular changes, just small curricular changes locally, and realizing when you had different stakeholder groups resisting the change, it didn't work. And so, and at that point, I wasn't savvy enough to understand what those resistance pieces were and how to manage those resistance pieces. So then I think based on our prior learnings, we realized that we had to do something different, and we had to understand readiness in a more meaningful way and had to go beyond a singular organizational snapshot. We had to understand readiness at the institutional stakeholder level. And when looking at the literature, it really that did not exist. I could not find anything related to individual stakeholder readiness. And so then we had to, take another pivot and say, how are we going to do this? How are we going to develop such a tool or instrument if it doesn't already exist? Yes, we have the organizational readiness, and yes, we can use that. It will help us with structure, culture, policy, infrastructure. But now we had to get into this individual readiness on beliefs, their confidence, their role adaptation, their motivation, really behavior change. And this became a turning point for us. This is where we really began to understand that readiness is not a side issue. It was the work we needed to do. And so most of the committee work had been focused on developing this readiness to change piece at the individual stakeholder level. So how do we go about doing this? We went about this by conducting stakeholder and focus group interviews. We conducted 35 focus groups across 7 stakeholders. We wanted to better understand the beliefs, the barriers, conditions, and behaviors shaping readiness to change. We went through the literature and took out every piece of literature that defined what was made success and implementation on individual stakeholder levels. Many of you on the call, we used your literature to help us, and so we thank you for that. I ultimately needed a framework to use, and so really we ultimately selected using this behavioral change wheel process. Behavioral change wheel is very well known in the literature for supporting patient behavior change. Not much done in education behavior change, but we decided, because this organizing framework also had a taxonomy that led us to interventions that could help develop the behavior change necessary, that this became a very good instrument and a framework for us to use in developing brand new individual stakeholder readiness to change instruments. If you're not familiar with behavioral change wheel, it defines behavior as capability, opportunity, and motivation. So when we went through the stakeholders in the literature, we used the 5 core components from Van Mel and defined the capability, opportunity, and motivation for 6 stakeholder groups across those 5 core components. And from this, we developed statements that became our statements on this readiness to change instrument. And we really address this from being at the initial implementation stage. So there's separate types of readiness once you're in it versus getting ready to get into it. So the instrument we developed is really to engage in that initial change towards competency-based education. So these readiness to change instruments have been developed. We're now piloting them now with some institutions, and hopefully get the validation for those instruments published very soon. The stakeholder groups that we have, because we're a degree program model. We have faculty stakeholder group, we have CEO deans, academic coaches, learners, and our preceptors. So that's the 6 stakeholder groups that we have readiness to change instruments developed for. So I believe overall, as we first approach this resistance, and being that one in the room when I had the resistance be a little bit more than I expected, after I was able to take that step back and really reflect from it and not just get upset and just give up from it, I realized that resistance really told us something important. It gave us a better way to understand what we were doing. I think resistance didn't just slow our journey, and then many people thought it has, because many people are like, why aren't we voting and moving towards this? I think it actually clarified our journey, and I think it's really important piece to take that step back. When you're doing something this big and you want it to stick, you do have to understand and clarify where you are and what needs to be done. So what looked like a delay is actually just design. We had to understand readiness before we could really ask people to change. Before we asked them to enact a different model, we had to understand what they believe, what they feared, what they understood, what they need in order to engage. And because those needs were so different across every stakeholder group, we had to do this in a very systematic, scholarly approach and study readiness rather than assuming that one organizational measure was going to be enough. So what began as a story of resistance became for us a story about readiness, stakeholder sense making, and the importance of studying the conditions for change before pushing too fast with implementation. We thought the early work would be more implementation, and what we learned the early work was really understanding this readiness to change.
All right, so I'm going to just close us out because we do really want to spend time in discussion here. Looking back, I think one of our most important lessons from this journey, and I'm sure this echoes many of your own lessons you've learned, is that resistance is easy to misread. It's easy to hear negative reactions and conclude that people are simply against change, right? It's easy to assume the work is failing before it has really begun. And probably for me, I really like sticking to timelines. And so that's also a part that sometimes you have to let go as these journeys. But if we stop there, we actually miss what resistance is trying to tell us. In our case, it surfaced very early. It surfaced before implementation. It surfaced while we were just exploring what it might look like in our profession. And it was the most striking thing was how quickly the term itself seems to change the tone of the conversation. The moment we named CBE, the room conversation shifted and it just became all about concerns about feasibility, disruption, and accreditation. And those really came to the forefront. And accreditation won't allow it became an automatic response, one that we still hear often. And once it enters down the conversation, it just shuts it down before we can even think through the deeper purpose of work with people. But we clearly found out that resistance was not a one size fits all. Does not mean the same thing for everyone. And faculty were not always reacting to the same concerns as administrators, same with learners and preceptors. And, people were responding to different things, uncertainty, role change, implications, absence of a shared sense, even that a major change was needed, like the why for competency-based education. And so this was a critical realization because it showed us that resistance was not one barrier. It was many signals coming from many stakeholders. And I think that really caused us to slow down and rethink our work. We used implementation science and we saw that readiness to change was not, peripheral to this reform. It was the foundation for it. And a lot of time was spent listening. So we did 35 focus groups with like over 150 people. Listening to people and understanding this was a key moment in our foundational work. And because this was a complex philosophical shift in the educational model, organizational readiness wasn't enough. We needed to look at that individual level, as it was clear from our focus groups. We need to look at their readiness, their beliefs, their confidence, their opportunity, and their motivation to make this change. And for us to slow down the implementation didn't mean we were stepping away from change. It just was taking it very seriously. It was recognizing that before asking people to make a change, to enact a different model, we had to understand first what they believed, what they feared, what they understood, and what they needed to move forward. So resistance didn't derail the journey. It clarified us. It showed us where we really needed to go, what the real journey was, and what the real work we needed to do to begin was. And I guess that's the larger lesson we lead with today. In the early exploration of competency-based education or any change, right? It's not specific to that. It's really anything. Resistance may be one of the most important forms of data we have. If we listen closely, it can reveal where language is getting in the way, where we're missing that urgency to change, where support is lacking, and where stakeholders might need something a little bit different before change can truly begin. And so our takeaway is resistance is not always the end of the conversation. Sometimes it is that clearest signal of where the conversation needs to start. And so that's our journey and our story today. And I will turn it over to Kelly and the moderators to move us forward.
Thank you so much, Alita. Thank you so much, Denise. Pretty profound commentary and thoughts, I would say. Things is that on the surface may seem inherently obvious, right? As I'm going through this, I'm like, well, of course. But you were able to call it out and again use the narrative through the journey that you had in pharmacy to help us get to a spot. I love the resistance as navigation idea and thoughts and themes and have lots of questions myself that come through that. Before that, though, I'm going to pull out a couple of questions that did come through during our conversation. So one is Ben asked, how do we navigate? Um, how do we differentiate or navigate the useful or generative resistance from the cynical, less helpful resistance? Because I'm sure not all resistance was hopeful, shall we say? Any thoughts or ideas with regards to that?
I'll just start, and then Denise, you can add on to what I miss. That's a great question. And so I'm a big fan of motivational interviewing and training my students to talk to patients. And, we have to kind of view that generative or that useful resistance as ways to improve our thinking, right? This is what we need we need that curiosity. We need those questions to make our work better. And so we should really lean into that type of resistance because it's going to improve everything in the long run. But the maybe the less helpful resistance, to quote motivational interviewing, we got to roll with that resistance. So explore it, understand their perspectives, work with them, and try and find ways to turn their skepticism maybe into some positive things. But either way, not resist it ourselves, not go against it and combat it, but try and explore it and better understand their perspectives along the way. Denise, what would you add?
Sorry, couldn't get to my mouse was lost for a second. I think that that was one thing about using behavioral change wheel. And I think it kind of goes into what Ole is saying. I was just reading his comments too about, should we really be tackling the resistance or not, and maybe focus on things that are more meaningful. I feel like that in any case, you're not going to get at tackling all of the resistance. I feel like the behavioral change will helped us to discern a little bit from what's real and what's not real, or you're not going to be able to tackle the less helpful resistance. Because when you focus on these things of true pieces that could help with the change, with, just opportunity, like there's just one little thing needs to be moved to give the person the opportunity to engage meaningful in CBE work that may have been hidden, that people didn't know about. I think that using this model helps uncover the things that do make a difference and help separate out from the parts that's not helpful. And I do believe on the comment, I'm just looking at what Ole had written here, is that I don't believe we can tackle and take away all resistance. But I think when you go into a room and everybody is so negative about everything that is wrong, I think when you start showing how you can remove some of those barriers, you can develop champions. And I do think champions are really important for change to occur. And I wasn't hearing very many champions when I first started talking. So we have to create some champions. And now I can tell you, and I didn't tell this part of the story, as I went back this year, this would, I guess, would have been what in 2023 was the story I told with the first encounter I had at the interim meeting. This interim meeting, I went back and shared again, and the room was very positive. Now, when you mention CBE, they still think you can't do it. But if you mention the core components and don't put CBE attached to it, they think it's wonderful. So it's a wording issue, just saying the word CBE. And I'd ask some questions intentionally to dig at that piece. And so I do think that using behavioral change wheel helps you navigate between which is bad and good, and helps you focus on tackling the things that you can tackle that are important for change, and that you realize you can't get every piece of resistance at all.
Okay, thanks for that. That it registers with me in my own world. A funny story. I did a qualitative interview once, and the question was, "Can you tell me what you learned?" And it was, "I didn't learn anything at all." And then literally the next sentence was, but what I learned was, and they would go on and did describe what they had. So they didn't learn anything, but they told me everything that they learned. The that tackling the resistance piece does seem to be something that is coming through a bit as a theme, and I know that was a lot of what your intent was to be able to get to that. Um, Take a step back, and because Kenji asked earlier, could that resistance come from not understanding what successful CBE looks like? From for learners and for patients. And for me, some of that might be simply how I would approach it would be I'm going to beat you over the head with how important this is for those other people and not had actually done what you guys did was listen, use some literature about change, resistance to change and change management. Any thoughts about that?
Uh, I mean, I think that, oh, I lost my train of thought. That's terrible. Um, I saw the capybara and I'm very distracted. I love it, Ben. So in terms of the resistance and change management and seeing examples, a lot of I got my train of thought back. So far, I will say pharmacists don't love change. And that's a very generic category, but we do struggle with change, categorization of us. But I think overall, a lot of times we want evidence. And so without examples in pharmacy education, and there are some emerging. I'm seeing some work coming out of Taiwan with the postgraduate education moving to milestones and EPAs. I'm seeing some work in Canada where there's been a pharmacy school built with a medical school in terms of CBE. But I think for us, seeing a tangible example of what this will look like made it hard because a lot of the examples are in residency training. And we're looking at starting a lot of this in the, under the 4-year PharmD part. And so without seeing like, this is exactly how it will look. Here's an example of a school that did it. And here's the resources we use, and here's the roadmap. It becomes very hard to understand what this might look like for you. You kind of see big things and maybe not understand the details. Now, we are starting to find more examples, as I alluded to in the literature. We also have one school that has actually implemented a lot of CBE, and it's one of the lowest resourced schools in the entire academy. And that is going to be an example we plan on highlighting, and that the dean of that school has joined our work so that we can continue to highlight that as well. Denise, what did I miss? Anything?
No,
Okay.
I think that was good. And I think I was looking also at Adele's comment or question as well. And it leads to all the questions being asked is it's about, is there something special about healthcare professionals as to why we think change is hard? And I do think that in our education and training, we're kind of trained and built. If we look at our clinical expertise, it's really based on pattern recognition and script formation and guidelines and standardization. And they represent a lot of stability and consistency and the known. And then we're coming in, and this framework is disrupting everything that you knew and was a shared model. So it kind of goes against sometimes the preferences. We try to avoid harm, right? That's our training. And so in pharmacists, to us, we always felt they were the worst. So I was really intrigued by Adele's comment that maybe it's not just us, that maybe it's all of us, and it's just in the healthcare space that we're in. And it kind of we have less tolerance for ambiguity, and we really scrutinize really new approaches. When a new drug comes out, we scrutinize it much more than an older drug, right? That may have much less data, but we scrutinize it a lot more. So maybe that is part of it. I do think it's also the pressures and cognitive load of adding something new on top of all the other things that we were asked to do as well. So I think there's a lot of things there. But I do think I really like the comment, and the most important comment that I saw here is that words matter. And that's one thing that I have said in our work is that we have to define every word we're using. And Alita knows that we define every single thing that we use, because I think that becomes the problem. They don't know what they're resisting because they don't even know the definition of it.
Hmm.
They don't know what it really means. They just are going to say something that would stop it. And the one thing that stops it, as I said in the story, is accreditation. Well, I'm writing a paper with the accreditation people. It's come in the near future. I've talked to them about it to say our current accreditation standards do not prevent CBE. And so, stop using that as the excuse. So I think it's just as more in having more conversations, and we constantly are having conversations with people to understand the words, but also defining everything in what we write and everything in what we say, we define it. And I that is the most important thing that I learned early on is words do matter. And when they say and asking them to define, well, what do you mean by that? Like, for example, for us, programmatic assessment is actually program assessment. They don't even know what programmatic assessment is. They think it's program assessment and we're already doing it. And I'm like, no, let's look at the definitions. It's not what you're currently doing. It's not just evaluating how well is a school functioning. So, so many things, but it does come down to words matter. So that was to me an important piece in the comment box.
Yeah, thanks, Denise. In so many ways, words actually matter, and in so many contexts. What should be relatively simple is far from that.
Mhm.
Claire, you had your hand up?
Yeah, thank you so much, Alita and Denise. This is really timely for me as I'm about to head into a 3-hour meeting on space needing to change. So you mentioned the new school in Canada, the new School of Pharmacy, which is a CBME-based school. Although it is housed in a medical school, like in a faculty of medicine, our faculty of medicine is not, for the undergrad, is not CBE at all. We're going into curricular change, and we are hitting some major walls, which is amazing, right? So we have this branch of pharmacy, which is way ahead of everything else. And it's like the left hand doesn't speak to the right hand. Uh, so I'm really appreciating the story you told us, and am going to use a lot, and we'll be in touch with you to help us with our curricular change in medicine.
And probably likewise, so we can chat and get lessons from you all in
Yes.
your pharmacy school.
We just published a paper actually on how curriculum
Yeah.
is governance for that school, really important. And I can send you a podcast as well, which is
Oh, that'd be
The
great, Claire.
podcast would be great.
yeah,
As I
it's
have the
really cool, and
paper,
it's really accessible. So I'll send you that.
Thank you.
Great talk. Thank you.
Thanks, Claire. John.
Alita and Denise says, great, thanks so much. I had two comments. One is, I don't know if it really matters for those that are, resistant or afraid, but it could be that it's certification standards rather than accreditation standards. I'm not sure if in pharmacy, whether there's a real divide or separation of the two, but I know for in the physician training, that's definitely the case. They're definitely separate standards. The second is I'm really curious about the low resource school, Alita, that you mentioned, because resources are often pointed towards legitimately as a barrier. And, uh, what can you tell us about that? Was it they found just some really neat low intensity way to implement it, or were they, in terms of like readiness for change and also just prep, foundational um, things that were present already to enable it? Like what can you tell us?
So I'll talk about it. I visited them recently and I'm working with them and writing up some of their work. It's the University of Puerto Rico School of Pharmacy. It's still part of our academy, our accrediting body here. Um, they have about 45 students. And I would say that the biggest thing that they did in their journey was start really understanding what they were doing and designing it for what their context was. So to me, those were two very important pieces. They spent years coming up with what they were going to do and getting the buy-in and building the buy-in and building the readiness before they actually did it. And then they adjusted everything to their context. Their portfolio system is all Google based, all free. They did their own training, faculty development for their coaching model. I would say the part that they're less robust with, and I'm working with them on, is a competency committee. Right now, they let their coaches make determinations on if they're ready to progress on their milestones, but they do have milestones. So I think they just took their context, but because they believe so deeply in what they were doing, and I will tell you that this year on our board exam, they had 100% pass rate. So that's one of the very few schools of pharmacy, and the national average is in the 80s. And they had 100% pass rate. So I feel like that they had the deep buy-in, and with that deep buy-in, then they were able to just use resources that they could have, they could find that were free, and get everybody working together in sync with the program. So it really did show, and it does show, and the dean speaks very highly. The resources is not your problem. The biggest piece is you've got to have the buy-in to begin with. And I think that's one of the big lessons in change management, is making sure people understand why you're doing what you're doing. And she did that
Yeah.
over a process of many years.
Hmm.
Yeah, I mean, in our institution where we had have a residency that has implemented a time variable model,
Mhm.
they were ready to do it, unlike many of the other programs in our institution, because they had their own motivations towards working. They were already wanting to work towards this, and it just so happened that we had a project to do it. But it does go back to your point about like what is the reason they're actually motivated to do it? Because that's what's in the end gonna the design, and the overcoming resistance will be much easier if it's self-motivated as opposed to imposed, or it feeling like it's imposed. So thanks.
Thank
Thanks,
you.
John. Ron, before I get to you, I was going to bring up one thing that was a little bit of a theme in the chat that Adele had raised it a bit earlier, and then Jan, I think, brought it forward as well, which really kind of gets to the resistance to change within our particular profession, and maybe or the health professions writ large. Maybe comment or think about, particularly as you did the research and kind of trying to find some evidence base behind this. We've consolidated and stuck, and Ben comments about that in terms of the unfreeze part of it. Do you think some of it is just the inherent nature of who we are as health professionals, that leads a little bit to resistance to change, or not? Did you come across that in your research and trying to think about how to best make this change?
So I think I think yes, Kelly. I mean, it's hard for me to. I think we knew, number one, going in, because we knew pharmacists don't want to change. Like,
Mhm.
it's hard just to, change where you put a label on something sometimes, it's just the very basic pieces. It's just very difficult, move where I put a chair in a room, it becomes a problem kind of thing. So I think we realized that was going to be a problem going in the very nature of it. And I often have said that I'm probably not the typical pharmacist, because I'm not very scared for change, and actually do understand and can handle change. So I mean, it's hard for me to understand it, I guess, because I'm not that type of person.
Mhm.
But I think we did anticipate it going in. I think that we didn't anticipate all the different things that we heard about it, and it may have been naive in not understanding how big CBE really was, and
Mhm.
how big of a change it was. So part of it could have been very naive to us because we weren't well versed in it. We read all the work of this group, and we were, fans of the ICBME group and reading all the work, and learned so much very quickly from the work of this group. And that's why it's been wonderful to be part of it now and continue to learn. But I do think that we did expect it, but I think the amount and the variation of it was a little unexpected.
Mhm. Yeah, in, for the record, we tremendously appreciate both of you in your work in bringing pharmacy into the CBME world, as well as other professions as well. Ron, you get the last question.
First of all, thanks for your helpful insight. You suggested that we should define everything. I wonder if it might help if we defined the different stages or 4 or 5 different stages in CBE. For example, stage 5 might be the move from time-based learning to outcome-based learning. And maybe the readiness may be different for these different stages. I mean, because that move from time to outcome based is one of the common things that stop people and upset and stop them progressing. So I wonder if we should define the different stages and say people's readiness may be ready to start at stage 1 and 2, but not to that final stage at 5, and not to worry about that.
Yeah. Ron, I think you're speaking my language. So this is something I have said along to our group and our committee. We follow the active implementation framework from Implementation Science primarily because I was familiar with it. It's from a UNC-based group that developed it, and it's what's used in K through 12 education in the United States. And along that model, Ron, it follows stages, just like you're talking about. The exploration stage is what I really think that we're in. So before you implement, then you have the installation stage is the early implementation. Then you have the early implementation stage and then full implementation stage. And what I suggested to our group is that you had a readiness to change instrument at each stage. And the stage that we developed first was this exploration to get you to installation. So I 100% agree that the work needs to continue. And as people do, and I was liking the full implementation to be the time variable piece, right? That to say you're fully implemented in CBE might be that time variable piece. And that's going to have a whole different type of readiness type questions, because you would have gone through those other stages to get you there. I have told people in pharmacy education that want to use time variable as the reason to not do it. I said, the time variable might be the easier piece. You've got to get the core components right first. If you don't get the core components right, there's no way that you're going to be able to do time variable, because you won't have the right structures to know if students are progressing, how they should progress, all those different things. And so, so I do believe that that's the next piece of this work, is to continue understanding and listening to these stakeholders and developing more of these instruments to get you across those stages. So you do get to that full implementation, which I would call time variable. Now, it might be better to redefine it in CBE terms, and I'm good with that as well. But this definitely follows the trajectory of the implementation science frameworks that we were using.
So Denise, what I heard you saying is we're going back to learn from, as we did with the very first implementation of competency-based education, which has been happening for decades prior to health professions education, where they were doing it in primary school. You're going back and actually telling us, oh yes, if you go back to primary school, they actually define the stages.
That's
And we in
right.
health professions educations, a half of a century later, are coming around to it. I say that jokingly, but it's actually a bit there's a bit of reality there as well. Um, I'm going to wrap up our time now, just to make sure we finish on time. Once again, thank you all for participating. Special thanks to Alida and Denise. Thank you for telling your story. It's been pretty phenomenal for us to go through and to hear from you. Many of us being in the medical education space and graduate medical education in particular, and then hearing the similarities, but also the differences in the journey that you've had, as well as literally what we can do to learn. You've really taught us how to best approach this as we go forward, particularly those that are still hesitant to do so. So thank you for taking the time to be able to share with us. Very, very valuable. Thanks to everybody else for participating, calling in, and engaging in the chat. We will come back again. I'm not sure we have a date set for our fourth installation for the this year's webinar series, but stay tuned to the usual channels, and we will, I'm sure, be able to communicate. And also a reminder, within a short period of time, I know Christina has to get things situated, but our conversation will be uploaded to our YouTube channel. And I'm sure information will follow with regards to that. Thanks, everybody. Nice to see you all. Have a great rest of your week.